All right, again. Hi, hello again, everyone. Thank you so much for joining us today for this special webinar. We're excited to have you here. A big thank you to CleanPop for sponsoring today's event and helping making it possible. To join, let me just share my screen. Just simply use your phone to scan the QR code you see it on the screen. And you can also share this link when you go here. You can also share this link with your family and friends by clicking the plus sign at the top right of the page. So then you can also screenshot or take a photo in the QR code. So with more further ado, let's dive into today's session.
All right. Well, thank you, Jamie. Hello, everyone. We are welcoming you to Sleep Village. I'm Dr. Raj Kakar, and thank you for joining us. Today, we're hosting a webinar on a very timely subject, sleep and obesity. We're very excited about this presentation by one of the world's leading sleep experts. It should be a very interesting and informative discussion. And would especially like to thank CleanPap for sponsoring this webinar and making this event possible. Now, we will be exploring how sleep can impact weight and overall health. This is a growing issue in the world today, and better understanding the link between sleep and obesity can be essential to improving health and well-being. Before we begin, I encourage our audience to drop your questions in the chat box throughout the presentation. And at the end of the presentation, we will reserve some time for Q&A to answer some of the questions received. I'm very excited to introduce our guest speaker, Dr. Atul Malhotra. He is the Vice Chair of Medicine and a clinician scientist at UC San Diego in California. Dr. Malhotra is widely recognized for his expertise in sleep apnea and respiratory diseases, with over 500 original research papers and more than 300 reviews and chapters published since 2000. Welcome, Dr. Malhotra.
Thanks very much. It's my pleasure to be here. I'm trying to figure out how to share screen here. Is that working?
Yes, now it's better. Yeah.
Okay. Is that good?
Much better. Yeah, now we can see it.
Okay, good. So by way of background, as I said, we estimate about 1 billion people worldwide with obstructive sleep apnea based on this paper published in the Lancet Respiratory Medicine. We published this study just before the SURMOUNT OSA result was released, looking at weight reduction and the impact on the apnea-hypopnea index, a systematic meta-analysis. On the y-axis here is the percent change in the apnea-hypopnea index. On the x-axis here is the percent change in body mass index. What we did here is did a meta-analysis of all the different weight reduction strategies. The blue guys are lifestyle, that is diet and exercise. The green ones are drugs like GLP-1 receptor agonists and other medications. The black ones are surgical, and the surgical weight loss had good results compared to some of the lifestyle changes. The tirzepatide result that I'm about to show you falls on this red line, suggesting that the changes in body weight could largely explain the changes in the apnea-hypopnea index. There's a lot of debate about the shape of this curve, whether it's linear or curvilinear, or whether there's a threshold or a dose response, but suffice to say, these are the available data. So in terms of SURMOUNT OSA, we'll talk about the design, efficacy, and safety. This is a complicated slide, but I'll walk through it. There's 2 different studies with SURMOUNT OSA, Study 1 and Study 2. Study 1 were patients who couldn't or wouldn't use CPAP therapy. Study 2 were patients who were on CPAP therapy. In Study 1, patients were randomized to tirzepatide or placebo. In Study 2, they're also randomized to tirzepatide or placebo. There's no direct comparison of tirzepatide to CPAP because it's been compared to placebo in both arms. People are tempted to say it's better or worse than CPAP. We can't say that based on these data. Tirzepatide is better than placebo is the conclusion we can draw. We went to the maximum tolerated dose of tirzepatide, so there's dose escalation over time. And in Study 2, CPAP was withdrawn for 1 week prior to the sleep study so we could assess the efficacy. Had we done the sleep study on CPAP, we would simply say that CPAP is working. It wouldn't tell you what the tirzepatide had done. You'll also see some improvements in the control arm in the placebo group. Everybody was given healthy nutrition and regular visits with registered dietitians and things, so it's not truly a placebo, it's the standard of care. In fact, it's a very good standard of care, which explains why the placebo group improves, as I'll show you. And we insist on at least 30% women. Women tend to lose more weight than do men with GLP-1 receptor agonists. Many bariatric studies are predominantly women because that's who shows up in bariatric clinics, but many sleep apnea studies are predominantly men. So we made a point of ensuring that we had a good gender balance with 70% at a maximum in terms of men and 30% women. The key inclusion criteria were age over 18, moderate to severe sleep apnea based on apnea-hypopnea index greater than 15 events per hour, and BMI over 30. We excluded people with type 1 and type 2 diabetes. People with diabetes tend to lose less weight than do non-diabetics, based on the SURMOUNT-2 study published in The Lancet, and so that's an important exclusion criterion. I'll point out there's nobody here who's lean or overweight because you have to have a BMI over 30. And there's no mild sleep apnea in here either. You have to be moderate to severe. So conclusions are limited in that context. Primary objective was to demonstrate that tirzepatide at the maximum tolerated dose once weekly is superior to placebo for the change in the apnea-hypopnea index from baseline to week 52. With key secondary objectives, and I'll emphasize that all of them were pre-specified and all were controlled for type 1 error, meaning we controlled for multiple comparisons. There was no fishing trip or data dredging here. Everything was pre-specified and controlled for multiplicity. So the goal here was to demonstrate that tirzepatide is superior to placebo in terms of the percent change in the apnea-hypopnea index, percent of participants with more than 50% reduction in the apnea-hypopnea index, percent of patients who might consider cured of their sleep apnea with an AHI less than 5, or 5 to 14 with an Epworth sleepiness score less than 10. We looked at the sleep apnea-specific hypoxic burden, which is thought to be a cardiovascular risk marker. We also looked at changes in systolic blood pressure, which was obviously important, percent changes in body weight, and changes in high sensitivity C-reactive protein, which we also know is a cardiovascular risk marker. We wanted to make sure the numbers weren't getting better while the patients weren't feeling any different, so we wanted to make sure we looked at patient-reported outcomes as well. The National Institutes of Health has developed the PROMIS scales. The PROMIS sleep-related impairment talks about daytime symptoms, and the PROMIS sleep disturbance talks about nighttime symptoms. So we looked at these patient-reported outcomes as well. And as a pre-specified design thing, we collapsed the two studies into one to look at these patient-reported outcomes. I'll show you throughout both the efficacy analyses and the treatment regimen estimate. The efficacy is based on patients who stay on drug. The treatment regimen estimate is based on the modified intention to treat. The results of the two are almost identical, but I'll show you both results, efficacy and modified intention to treat, as we go through these data. There's a graphical approach to strongly control for type 1 errors I've emphasized. When you look at the drug discontinuations, they're relatively few. In study 2, it's actually slightly more in placebo than with tirzepatide. If you look at withdrawal by subjects, they're also relatively rare. Some of the placebos drop out probably because of lack of efficacy. When you look at the baseline characteristics, they had severe sleep apnea based on apnea-hypopnea index of 51 events per hour. Moderate to severe, we excluded mild, as I mentioned. In terms of patient-reported outcomes, they were abnormal, shown there. They're minimally sleepy. These patients came from bariatric and endocrine clinics, not from sleep clinics, and so the degree of sleepiness was less than you might see in a sleep clinic-based cohort. So primary objective was to demonstrate that tirzepatide once weekly was superior to placebo for change in the apnea-hypopnea index. Baseline characteristics of retention of participants during the study reassures clinicians that the results are likely to be similar in clinical practice. So I'll show you the results now. This is looking at efficacy and safety of tirzepatide for sleep apnea. And as some of you know, this was recently published in the New England Journal of Medicine, tirzepatide for the treatment of obstructive sleep apnea and obesity. The primary outcome was the apnea-hypopnea index at 52 weeks. The efficacy analysis is shown here. The modified intention to treat is shown here. Study 1 of the non-CPAP patients, study 2 of the CPAP patients. You can see a clinically and statistically significant improvement with tirzepatide in both the efficacy analysis and the modified intention to treat in both study 1 and in study 2. About 30 events per hour improvement is quite good with a baseline of 49. So marked improvement in sleep apnea severity. That was our primary outcome. Key secondary outcomes, we looked at the percent change in the apnea-hypopnea index. The percent change here was 50 to 55%, whether you're looking at the efficacy analysis or modified intention to treat. Similar results in study 2, if anything, a little bit more, about 60% improvement in the apnea-hypopnea index at week 52. Looking at the number of patients with a more than 50% reduction in the apnea-hypopnea index, which we feel is probably clinically significant. You can see in study 1, about 60% achieved a 50% reduction in AHI, and study 2 is closer to 70 or 75% received a 50% reduction in the apnea-hypopnea index. If you look at the percent of patients you might consider cured, that is, they end up with an apnea-hypopnea index less than 5, or an apnea-hypopnea index between 5 and 14 with an Epworth sleeping score less than 10, you can see it's about 40 to 50% of patients in the modified intention to treat analysis, and about 40 to 50% patients in the efficacy analysis you might consider cured. Now, there's some debate about this. If the AHI is less than 5, nobody's going to continue CPAP. That's about 30% of patients in that category. There's lots of reasons we treat mild sleep apnea, though, particularly not just the Epworth scores. And sometimes we treat it for hypertension or non-restorative sleep or fatigue or other reasons. And so you might not consider all these patients cured, but certainly enough of them got into range where you might be able to consider them either cured or largely well treated. We look at the hypoxic burden. Study 1 on the left, these are the non-CPAP patients. Study 2 are the CPAP patients. The efficacy analysis showed about a 70% improvement in the hypoxic burden and about a 75% improvement in study 2 in both the efficacy analysis and the modified intention to treat, suggesting this cardiovascular risk marker was markedly improved with tirzepatide therapy. In terms of cardiovascular outcomes, we're seeing changes in body weight. The efficacy analysis had about an 18% improvement in body weight in study 1, and study 2 is about a 20% improvement in body weight in the non-CPAP patients at 1 year. Just to put that in context, if you weighed 200 pounds and lost 20% of your weight, you'd be down to 160 pounds. 40 pounds of weight loss would be quite staggering, and so that's the average that we're seeing at 1 year in study 2. If you look at high sensitivity C-reactive protein, the modified intention to treat on the left, the efficacy analysis on the right, you see about a 40 to 50% improvement in high sensitivity C-reactive protein in the modified intention to treat, and about a 40 to 50% improvement in the efficacy analysis in both study 1 and study 2. As I emphasized earlier, there are some improvements in the placebo group as well, which is good news in the sense that the diet and exercise and these things that we're doing in the control group were at least partially effective. If you look at systolic blood pressure, this is perhaps the result that surprised me the most, a 9.5 millimeter mercury improvement in systolic blood pressure in study 1, about 7.5 millimeter mercury in study 2, and similar results in the efficacy analysis shown here on the right. We look at patient-reported outcomes. As I mentioned, we pre-specified a pooled analysis where we combined the PROMIS scales. And if you look at sleep-related impairment, that is daytime symptoms, and sleep disturbance score, that is nighttime symptoms, a marked improvement in the pooled analysis here with tirzepatide therapy versus placebo. Very similar result here for sleep-related impairment. Tirzepatide lead to marked improvement in the pooled analysis shown here on the left. So to summarize the efficacy, tirzepatide demonstrates superior and clinically meaningful improvement of sleep-related breathing compared to placebo. Tirzepatide demonstrates superior improvement of sleep-related functioning and quality of sleep compared to placebo. Tirzepatide demonstrates superior improvement of cardiovascular risk factors. That's based on the sleep apnea-specific hypoxic burden and the C-reactive protein. Type 1 error was controlled for all the things I showed you, the change in AHI, hypoxic burden, patient-reported outcomes, systolic blood pressure, high sensitivity CRP, and changes in body weight. Let's talk about safety. There were side effects which are known to occur with these kinds of medications. The majority of the treatment emergent adverse events were gastrointestinal. So you see nausea, vomiting, diarrhea. See more in tirzepatide than with placebo in study 1. Very similar pattern in study 2. You see more nausea, vomiting, diarrhea. The good news is these are generally self-limited and generally did not lead to dropouts from the trial. And so these are known side effects that go away over time. Adverse events of special interest. Acute pancreatitis was seen in 2 tirzepatide patients, none in the placebo. And so out of almost 500 patients, we're seeing 2 cases of pancreatitis. There's concern about pancreatitis with these GLP-1 receptor agonists. So I did a deep dive on these two cases. I'm a critical care physician as well, and so I know a lot about pancreatitis from that context. And so I did a deep dive in these. Both these cases were quite mild. I wasn't sure exactly why they were diagnosed. What I surmised from the available information was that there may be an ascertainment bias here. People come in with nausea, vomiting, abdominal pain, people checking amylase and lipase because they're on a GLP-1 receptor agonist or in a trial. So there may be some overdiagnosis here, I guess. But the two cases are seen out of almost 500 patients and not to be ignored. So key takeaways there: tirzepatide maximum tolerated dose demonstrated superior and clinically meaningful improvement of obstructive sleep apnea-related sleep disorder breathing. Tirzepatide maximum tolerated dose demonstrated superior improvement of patient-reported quality of sleep and sleep-related functioning. Treatment with tirzepatide maximum tolerated dose translated to clinically meaningful improvements in obstructive sleep apnea and obesity-related cardiovascular risk factors. And the safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. So I'd like to stop there. I'd like to thank you all for your attention. It's been my pleasure to be here today.
Well, thank you. Thank you, Dr. Malhotra. Looks like we have some time for some questions, and we had a couple of questions from the audience. Just wanted to see if we could share a couple of those. So I guess one of them is, we have a question as far as, I guess, how do you see, Dr. Malhotra, the use of the GLP-1 agonists like tirzepatide being used for management of sleep apnea? Do you feel like looking forward it may be part of the regimen treatment plan, or is it something that could possibly replace CPAP? There are some questions related to that.
Yeah, it's a good question, and the answer is I don't know. We submitted to the Food and Drug Administration on June 21st, the day I presented at the American Diabetes Association, the top-line results. So we're waiting to hear back. It was a fast-track designation, and so we'll see what they say. That said, there is a FDA approval for tirzepatide for people with obesity, a BMI over 30, and so you could use it in that context as a medication for obesity. What I emphasized at the beginning, though, is that there's no direct comparison to CPAP. So the standard of care hasn't changed. First-line treatment is still CPAP, but standard of care has always been to treat the whole patient. Diet, exercise, and sleep are the three pillars of health. The Cherno study in New England Journal of Medicine 10 years ago showed that you treat either obesity or sleep apnea or both. The answer is both. You treat obesity and sleep apnea if you want to improve systolic blood pressure and insulin sensitivity and lipids and all the rest of it. So that hasn't changed. What changed is we have more effective treatments for obesity now. And so what I always say is if diet and exercise are highly effective, I'd be skinnier. And so we now have medications that we can use to help facilitate weight loss, which may be useful adjunctive therapies with CPAP. There's no direct comparison to CPAP, as I've emphasized, but those will be subsequent studies probably done down the road.
Mm-hmm. Mm-hmm. Very good. And we have a couple of our audience members have questions related to the quality of sleep and how sleep quality plays into weight and metabolism. Can you kind of give a little bit of background on that? Yeah,
so we know that sleep deprivation can lead to changes in leptin and ghrelin, which are two hormones that regulate appetite. Leptin is a satiety hormone that tells your body to stop eating. Ghrelin is the opposite. It promotes appetite. If you sleep deprive people, their leptin levels are suppressed and ghrelin levels are increased. And so in randomized studies out of the University of Chicago, Ed Van Cotter's group has shown that both hormones go in a direction that be predicted to stimulate appetite. So with sleep deprivation, both hormones go in a direction that be predicted to stimulate appetite. And we were able to analyze the data from the Nurses' Health Study, look at progressive changes in body weight over time. And women sleeping reporting 5 hours of sleep per night gained more weight over time than those sleeping adequately, 7 or 8 hours. And we published that. Sanjay Patel was the first author in the American Journal of Epidemiology about 20 years ago now. So it's obviously an important component. Your mother was right that you need adequate sleep for metabolic health and for other reasons.
Yeah, wonderful. Yeah, that's great. That's great. And so, yeah, there's, obviously that connection is there, and it really just is very important to remember to make sure we're getting enough sleep as well. How about as far as one question I had for you was related to tirzepatide in particular, with some of the, again, new GLP-1 agonists. There have been some reports that there may be some development of sarcopenia or muscle loss along with the weight reduction. Is that something that you've seen, or was that one of the side effects that were considered during the study?
Yeah, certainly that's an important issue. All these major companies, Eli Lilly, Novartis, everybody's working on skeletal muscle agents now to try and preserve skeletal muscle. The bottom line is the following. If you just starve yourself, I just stopped eating, I would lose fat, but I'd also lose muscle. And the reason that's problematic is you need skeletal muscle for your basal metabolic rate. And so it becomes very hard to sustain weight loss if you don't have skeletal muscle to burn calories for you. And so it is a concern there that if you're just starving or if you just stop eating, that you'll lose skeletal muscle and not be able to sustain the weight loss. So people are working on various agents to try and preserve skeletal muscle. But the other thing to emphasize is we didn't do just medication in isolation. We do diet and exercise with it. And so a little bit of strength training, that kind of thing, can help preserve skeletal muscle. At least in some animal models, the skeletal muscle is relatively preserved compared to adipose tissue. And so it is a real concern. It is an issue. There's even some discussion about the upper airway muscles being affected as well, which might be important in sleep apnea. But suffice it to say, that's areas of further research in the future.
Excellent, excellent. Well, that's great. Yeah. And let me see. We have several more questions, but I can try to see if we can get one or two more in here. I guess here, let's see. I guess there's just a general question from one of the audience members is, what are some practical steps individuals can take to improve their sleep quality, especially if they are struggling with weight management?
Yeah, how to improve your sleep quality is sort of a individualized kind of thing. It's a longer conversation than we probably have time for today. It sort of depends what your underlying cause is and what your issue is. Certainly, as I've emphasized, diet, exercise, and sleep are the three pillars of health. And if you ignore one, the other two will suffer. So exercising regularly can help you sleep at night. My wife has bad insomnia, but she sleeps well if she exercises regularly. So I tell my patients that, and there's plenty of data to support that in the literature as well. Other behaviors can affect sleep quality at night, though. So obviously alcohol, tobacco, caffeine, all these things can disrupt sleep. Erratic schedules can as well. So if I take a nap on a Sunday afternoon, I can't sleep Sunday night. Not because I have insomnia, but because I'm not tired. And so sometimes just cleaning up the schedule can be quite helpful as well. Again, that's something you individualize and talk to your doctor about.
Yeah, that's great. That's great. And I have one more here from another member of the audience. This is a kind of interesting question because it also relates to irregular sleep schedules. So, for those working graveyard shifts, is there a higher risk of developing obesity-related sleep disorders such as sleep apnea?
Yeah, certainly there are some data suggesting shift workers are at risk of a variety of health complications, including increases in body weight and probably risk of myocardial infarction. There's actually some cancer risk as well that's been reported in some shift workers, so it is a real issue. In general, shift workers sleep less than people that sleep on a regular schedule, so prioritizing sleep can be quite helpful in that context as well. The joke that's often said, my friend Safwan Bader in Detroit always says this, he said, nobody craves salad at 3 o'clock in the morning. And I think that there's some truth that you tend to be, when you're sleep deprived, you tend to crave the worst foods. And that's probably, a take-home message there in terms of if you are in a shift work situation, make sure you prioritize sleep and don't eat garbage in the middle of the night, which many of us are prone to do.
Yeah, that's definitely a good point and well taken. Yeah, well, thank you, Dr. Malhotra, for sharing your expertise with us today. Thank you for the wonderful presentation of the latest research in sleep and obesity. And it was a great discussion, and I'm sure our audience found it both informative and helpful. Thank you again, Dr. Malhotra.
Thank you so much.
And also now I'd just like to remind our audience that we are having the upcoming webinar on our next webinar is Tuesday, October 22nd at the same time, 12 noon Central Time. We'll be joined by Dr. Karen Johnson to discuss another important topic, which is very timely as we approach daylight savings time. And the topic title being Daylight Savings Time, is it still worth the trouble? And so we'll have that conversation as we discuss that issue in our next week in our next webinar. And before we wrap up, I want to thank everyone again for joining us today. Your engagement is what makes the Sleep Village community special. And thank you again to CleanPath for sponsoring this webinar. Jamie?
Okay, so yeah, I just wanted to thank again everyone who participated in today's event. So we really truly appreciate your time and energy. So again, just a reminder, don't forget you can invite your family and friends to join Sleep Village. So you can just click here, the sign button, and then you can also screenshot or take a picture on the screen below. All right, so well, feel free to take any picture and share it, and then let's work together to make Sleep Village a place where everyone can find the help and support they need for better sleep. We hope to see you there. So thank you once again for being part of today's webinar. Until next time, sleep well.